as far as the etiology is concerned, nobody knows anything. There is, like acute pancreatitis, there is one theory that called protein plug theory. That means, you know, if we remember the anatomy of the pancreas, so it goes something like that, and this is the main duct, and this goes somewhere over here, and there are multiple side branches. So it is a combination of an exocrine and endocrine organ. So and it secretes powerful enzymes. They say that for some reason unknown to us, these enzymes, they are rich in protein, they get precipitated within the small side branches, and that side branches, they are on calcium deposits on them. So it is some kind of obstruction to the drainage system of the exocrine part of the pancreas. However, that is one theory. There are many other theory like that you will read from the book. They are toxic metabolite theory. I mean, in this theory, they say the very high calcium and the direct toxin that you all appreciate. What is that toxin? You all love it to consume in large number on weekends. Huh? Jore bol. Be proud about it. Alcohol. So alcohol, they are the most important, they cause about 90% of it. They are so important. So this alcohol is a direct toxin, and so is another electrolytes that also causes acute pancreatitis, that is also causing, that is calcium. Hypercalcemia is another cause, and whatever causes hypercalcemia, that means hyperparathyroidism. Hyperparathyroidism. They also cause pancreatitis. Whatever happens, you need to remember the definition of pancreatitis, chronic pancreatitis. How is it separate from, and there is another one, recurrent acute pancreatitis. Some of these patients, recurrent acute pancreatitis can proceed into chronic pancreatitis because of some stricture or narrowing in the pancreatic ductular system. One thing that protects against carcinoma stomach, important, vitamin C. And one that precipitates, that can come as a short note, that seta porbi, seta hoche Menetrius disease, hyperplastic gastropathy. So chronic pancreatitis is definition এ তিনটে জিনিস মনে রাখতে হবে. It is a, যদিও এই দুটোর মানে আলাদা আলাদা কি আমি জানি না, পার্মানেন্ট irreversible loss of function. So it has been accepted that it is an inflammatory change in the pancreas that brings permanent irreversible definition, but permanent means irreversible. What does it difference? But it is a permanent irreversible loss of function of both exocrine and endocrine pancreas. So that is an inflammatory process. Why it happens? এর মধ্যে প্রচুর theory আছে. I am not going into that. Protein plug theory টা examiners will know. They will ask. এছাড়া তোর ischemic theory একটা আছে, nociceptor hyperstimulation সেটার জন্য হয়. So these theories are there, but basically what happens, either in the main pancreatic duct or in the side branches, there will be multiple obstruction. That obstruction may be due to protein plug, or there is an actual stricture in the main pancreatic duct. So that's why যখন একটা established pancreatitis হয়ে যায়, তুই যদি ওই পেশেন্টটার ইআরসিপি করিস বা এমআরসিপি করিস তাহলে একটা টিপিক্যাল ডেসক্রিপশন হয়, অর্থাৎ প্যানক্রিয়াটিক ডাক্ট বিকাম লাইক দ্যাট। So multiple dilatation and intermittent stricture, they are called chain of legs. Chain of legs. এই ডিফর্মিটিটা খুব স্পেসিফিক অফ ক্রনিক প্যানক্রিয়াটাইটিস, দ্যাট ইজ ইম্পর্টেন্ট। এরপর আমরা আসছি তাহলে হোয়াট আর দ্য ফাংশনস। ইউ সি দেয়ার আর টু ফাংশনস মোস্টলি, ওয়ান ইজ exocrine, the other is endocrine. There is an order of destruction. Initially it seems এখানে কি খুব ডেঙ্গু হয়? অল দ্য সার্জেন্স আর সাফারিং ফ্রম ডেঙ্গু। আমাকে সকাল থেকে ফোন করে যাচ্ছে কেউ একটা গল ব্লাডার অপারেশন রেখে দিয়েছে, এদিকে ওপিডি আছে, এদিকে ক্লাস আছে। আই ডোন্ট নো, আই নিড টু বি somebody with lot of hands, octopus. So কি বলছিলাম জানো? What I was talking about? Exocrine and endocrine, yes. So you see the order of destruction is exocrine and then endocrine. So জানিস তো ভগবান has given us lot of reserve, like the liver that we have been provided. Probably God also wanted us to destroy a part of liver. If you divide the liver into 8 parts, if you remove the 7 parts, that 1/8 of the liver is good enough to live a normal life. So 7 reserved for alcohol, 1 reserved for life. Similarly, in case of pancreas, it is the exocrine function that gets damaged early. You know, the average duration of alcohol abuse should be about 13 years. So after 13 years of continuous alcohol is the commonest cause of pancreatitis. So that is why you see we have so much of reserve that even it takes on an average about 13 to 15 years to get the symptoms of chronic pancreatitis. And what it is always the exocrine function that is lost early. So exocrine function loss, it happen first and followed by endocrine function. That means the patient will develop the features of diarrhea, steatorrhea, or weight loss. These are the functions of exocrine function loss because it is protein enteropathy moto ekta symptoms of it. So that will precede the diabetes. The diabetes will come later. Okay, now, so what else? What is the predominant symptoms? So symptoms, এই মাঝের গুলো সব লাগিয়ে দিতে পারবি। The symptoms is diarrhea, bloating, dyspepsia, all these facts. I am only highlighting the important one. Diarrhea, exocrine function loss এর মধ্যে বলছি। প্যানক্রিয়াটাইটিস এর symptoms বললে মুখ দিয়ে একটাই কথা বেরোবে। What is that? Severe epigastric pain. The importance of pancreatitis as far as surgeon goes, কি বলছিস? Severe intermittent acute pain হয়। Pain, chronic pancreatitis. Pain is the predominant feature for which a patient of pancreatitis will consult a surgeon. I am not saying it is the commonest feature. Commonest feature will be the diarrhea, steatorrhea, all these vague GI symptoms. But do they come to a surgeon with all these symptoms? যদি বলে একটু অম্বল হয়েছে, ব্যথা লাগছে, পেটটা ফোলা লাগছে, where do they go? They go to the body doctors who give bodies, tablets. So go to the medicine. Surgeons are concerned only when patients are forced to come. What forces the patient of a chronic pancreatitis to consult a surgeon? Please don't forget, severe epigastric pain. That is when they come to a surgeon. I am not saying it is the most common symptoms. So, what are the important? Diarrhea and steatorrhea. Steatorrhea means, you see, the pancreatic enzymes contains lipase. So, the lipase is important to digest the fat, and not only the fat-soluble vitamins also. So, because they are, how will you differentiate a normal stool from a steatorrheic stool? The patient ki? Yeah. So, steatorrheic stool usually float in the, they need to have commodes everybody. But in our country, many people defecate on the roadside. So, they won't be able to differentiate between steatorrhea and diarrhea. But steatorrhea, it floats. So, why it happens? It's because of the fat malabsorption. Fat malabsorption manifests mostly in the deficiency of fat-soluble vitamins. So, many of these patients actually suffer from vitamin D, vitamin K, আর কি আছে? Vitamin A. So, these two are very important. Because they suffer from vitamin D deficiency, most of these patients are also osteopenic. And vitamin K, the improper coagulation. So, many of these patients, in a florid case of pancreatitis, they present with osteopenia, they also present with hello? আমার দুটো হাত আছে, দুটো হাত আছে. I am right now taking a class, and after that I will go to the OPD, and you are calling me to go to the OT. Which one Shantiniketan Medical College wants me to go? If you don't have anybody, সোহম স্যার আমার সাথে কোনো কথা বলেননি. আপনার যদি ওই কেসটা করতে হয়, that need to wait. After the class will finish at 11 o'clock, then only I will go. You know, you need to cut down on certain cases. You can't accommodate. You employ one person and give 4 jobs at the same time. Nobody can do it. Thank you very much. So, osteopenia and coagulation. Okay, these are very important factors. You know, this happens, steatorrhea happens, suppose the maximum exocrine function of a pancreas is 100. So, this steatorrhea happens only when this maximum exocrine function reduced, which is normal taken as 100, to about 10% of maximum capacity. That is when all the symptoms come. So, this 90% needs to be damaged before any symptoms of steatorrhea, diarrhea. That means what I am trying to say, pancreas has got an enormous reserve. So, how will you diagnose chronic pancreatitis? Yeah, clinical diagnosis of course, but for surgical point of view, even the background of diarrhea and steatorrhea, always focus on severe epigastric pain. That is the presentation to the surgeon. That is what the surgeons will want to know. And we leave all the dirty part to the other logist, microbiologist, pathologist. So, we send 1 gram of poop of the patient, 1 gram, and send it to the laboratory to measure elastase 1. Yeah. That measurement in the feces, not in the blood. So, 1 gram, its value will be microgram per gram of stool. So, it should be much higher than that. When it is reduced below 200, then the possibility of chronic pancreatitis is established. This is the most important diagnostic tool to diagnose chronic pancreatitis. So it should be less than 100 microgram per gram of stool. So elastase 1 is a very important thing. This is important for the medical people and it is measured to diagnose chronic pancreatitis. From our side, what we do, very commonly whenever there is a protein precipitate, it is invariably followed by calcium deposition. So if you do a straight X-ray and suppose in the X-ray you will find this vague এরকম করে যাচ্ছে একটা X-ray epigastric region এ, then you can suspect that there may be chronic pancreatitis because these calcium deposits are within the pancreas. So this is a screening test. The gold standard to diagnose chronic pancreatitis, you must remember what I am saying, gold standard. But that doesn't mean gold. Everybody do not wear gold. They know imitations. So because imitations are of choice. But the gold standard is ERCP. They will tell you everything. If there is a stricture, if there is a stone, if there is a side branch blockage, or if there is a side branch rupture that releases the juice and that causes, yesterday we were talking about pseudocyst, that was acute pseudocyst. In chronic pancreatitis, they produce a fully well developed thick walled chronic kothata bole na pseudocyst. So what I am saying, the gold standard is ERCP, but as you know that ERCP has got certain complication and morbidity. In 3% it causes severe acute pancreatitis itself. So ERCP is to be used very logically, not for every patient, whenever it is indicated. And for pancreatitis, this is the gold standard, but not done for everybody because it is an invasive test. Whenever we have got two tests giving more or less equivalent result, one is invasive, the other one is non-invasive, we should always go for non-invasive. So the non-invasive test, which is the test of choice, is CT scan. MRI also can give us an idea, but the specificity and sensitivity of MRCP or MRI is pretty low. To diagnose chronic pancreatitis, this is the test of choice, but against this one, this is the gold standard, against which we measure and we expect that they give more or less equivalent sensitivity and specificity. As for this ERCP, ধর এখানে একটা পাথর আছে, এখানে একটা স্ট্রাকচার আছে. So the ERCP can also be therapeutic, just like we do in bile duct stone extraction by ERCP. We do papillotomy, we take out the stone and we do stenting. That's right. Similarly, it has got a common opening. Pancreatic duct or bile duct, they are guarded by and this part is within the wall of the duodenum. So they have got a common channel. So go through that, you do this same sphincter. The sphincter of Oddi is same. There is no separate sphincter for the pancreatic duct and a separate one for bile duct. So you do the sphincterotomy, make this one a bit bigger, you put in a thing, you can take out the stone and then put in a stent inside, just like a biliary stent. Pancreatic stent can be done. But you remember, it is not that easy. It is possible only when there is a solitary stone or stricture. মানে একটাই আছে, একাধিক যদি অনেকগুলো স্ট্রাকচার থাকে, you cannot do that. Most of the stricture and stone are located within the head of the pancreas. That means very near from the there. এইখানে যদি একটা স্টোন থাকে, they won't be able to take it out. So this is how we diagnose chronic pancreatitis by basis of CT scan. There is role of ERCP, it is the gold standard, and MRCP can complement, but these are all are just simply X-ray te often the calcification means in the parenchyma. আর যদি stone হয়, that has to be a concretion within the ductular system, is usually the main duct. Now then, what will be the treatment? This part is very important. এটাই তোদের পড়তে হবে. So treatment, obviously we leave the initial part to the people come to the surgeon in distress only when the tablets and everything has not functioned, then only they come to the, even for pain abdomen, appendicitis, they go to the general physician, and general physician sends it to the surgeon when he thinks, and in between what comes, all the aberrations of our moral degradation of practice. That means the physician, he is the physician, we are the surgeon, he will send it to you provided you give him something in cash or kind. Unfortunate it is, but that's how it happens. That means je amake beshi paisa debe, so the every physician has got a select surgeon, and you must know, it should not be said that's how it goes, but it shouldn't be. So first medical management এর মধ্যে প্রথম যেটা দেওয়া হয়, you see, ব্যথা কমানোর জন্য কি কি দেওয়া যেতে পারে. We have got armament of all kinds of painkillers. They should be tried, but what is very important, it has been shown that first advice যেগুলোর জন্য হয়, so reduce alcohol. যারা অ্যালকোহল খায় তাদেরকে অ্যালকোহল and smoking, these two are very important precipitating factors of pain. Suppose a patient comes, so tell them to stop taking alcohol and smoking. These actually help 60% of the patients from getting the acute pain, not the disease itself. The disease may progress slowly, but the episodes of pain goes down. So this should be the first line of treatment. Second line of treatment, we give, sorry, this is the first. Second line of treatment is enzyme supplementation. So in chronic pancreatitis, because the disease is progressive, most of the parenchyma of pancreas becomes replaced by fibrosis. So there is hardly any functioning exocrine glands left when the patient reaches the doctor. So if you can supplement it externally, যে একটা ওষুধ পাওয়া যায় ক্রেয়ন বলে, there বিভিন্ন নামে আছে, this is a very popular medication. This medication, that means you are giving artificial trypsin, lipase and all these enzyme preparations, and that the patient should take with meal. That means the advice should not be given before meal, after meal. You will take one chapati and then take the tablet and then finish the rest of the dinner. So that actually helps a lot. And the third management is painkillers. They are to be given in a very measured manner and a graded fashion. At the initial part, we give something like acetaminophen group of drug. They help, but after some time they become ineffective. What should be our idea? These people, এখন এবারে জিএসটি এলিভেশনের ট্যাক্সেশন দেখেছিস, জিএসটি রেশনালাইজেশন, কি কি ট্যাক্সেশন আছে হয়েছে? 5, 18 and 40%. এই ট্যাক্সটার নাম দিয়েছে সিন ট্যাক্স। সিন ট্যাক্সের মধ্যে কি কি আসবে? আনফরচুনেটলি for considering our preference, they have excluded alcohol from that. They have taken in cigarettes, gutka, and all these things, apart from the luxury cars or anything. So what I am trying to say, so this taxation, আমি কি বলতে যাচ্ছিলাম? Addiction is a both way thing. One is the physical addiction, the other is the behavioral part. তুই যদি একটা স্মোকারকে হাত দুটো বেঁধে মুখের মধ্যে সিগারেট দিয়ে দিস, he won't get the full benefit. The chewing gum I am chewing now, it contains nicotine. So I was a heavy smoker and I stopped it in 2013. I was not born at that time. 2013. তাহলে তুই এতদিন পরেও আমি কিন্তু ছাড়তে পারিনি। So what I am trying to say, এই যে সিগারেটটা বের করবে, একটু ঠুকবে, তারপর দেশলাইটা নেবে, this is called the amage. You know, that has got a huge component of addiction. It is not the nicotine. Nicotine you can supplement, but the whole thing, so what I am saying that one, if a person becomes addicted, then he is prone to get different kind of addiction. That is true. It is a behavioral sciences. So what we need to be very careful, most of the patients of chronic pancreatitis are addicted to alcohol. As I said, 95% of them is due to alcohol. So we should not be giving opioids liberally to them, because then they will come back with pancreatitis with addiction to opium. So সেই জন্য opium মানে different preparations are there, they get addicted. So our target of treatment should be to give as little opioid supplement as possible, but most of these patients after acetaminophen, NSAID is completely no for patients of chronic pancreatitis. So NSAID is a no. So what option do I have? After that we go into opioids, but this opioid treatment should be a monitored treatment. That means drug to be disposed by the pharmacy in a very measured manner so that they don't get addicted. And if it does not work, তারপরে medical people হাত তুলে দেবে. That's it. I can go up to this one, and then nothing we can do. After that, this patient comes to the surgeons. So এই ট্রিটমেন্ট গুলো মেডিসিন দিতে পারবে, তারপরে ওদের আর কিছু নেই, then they send it to us. So all these things I am focusing purposefully. The thing you need to say and you need to write in long cases, it is the pain of chronic pancreatitis that is for surgeon's attention. অন্যগুলো পড়বি, but pain is the pain relief is the purpose. সার্জনের কাছে আসলে you have got only two options. One is to contemplate surgery, the other one is neural blockade. Suppose this patient of pancreatitis is a very old patient, has got other comorbidities which is quite common in them, and he is not a very good candidate for surgery. For those patients we go for the second option, neural blockade. Neural blockade কি করা হয়? Yeah, so you basically celiac plexus you can block it or you can excise it. So if it is excision, then it is a surgical excision. If it is a blockade, you give something very toxic like formaldehyde or anything. Sometimes steroids can be given, but basically we destroy the celiac plexus from which all those nociceptive receptor knobs are coming, and the patients will get relief from pain, but they will not, their disease as such will not be altered. So the next part, that is the part of surgery that has to be done. So only two types of surgeries are there. One is drainage, the other one is resection. এই দুটো ধরনের প্রথমে সার্জারি, টু টাইপস অফ সার্জারি। এই সার্জারিগুলো সবসময় কোনো কোনো সাহেবের নাম দিয়ে আছে, সো ইউ উইল হ্যাভ টু রিমেম্বার। বাট সাহেবের নাম যদি মনে না রাখতে পারিস, অ্যাটলিস্ট হোয়াট ইজ বিং ডান if you can describe, that is good enough. You don't have to remember those colonial hangover names that have been imposed on us. But obviously তুই বুঝতে পারছিস এই যে প্যানক্রিয়াসের প্যারেনকাইমাটা অনেকটা নষ্ট হয়ে যায়। So our focus should always be more on the part where we can restore whatever remnant pancreatic tissue is there. In case of a drainage procedure, we do not resect any pancreatic tissue. So drainage procedures are always preferred. And when they don't function, they don't work, or something else is there, then we go for the resection. Resection will obviously remove a part of pancreas. There may be some functional pancreatic tissue, so we do not prefer that. But to have a drainage, you can drain only when the pancreatic duct is dilated. Otherwise, it is not a microscopic surgery. একদম একটা সরু প্যানক্রিয়াটিক ডাক্ট, নর্মাল মেজারমেন্ট হচ্ছে 2 to 3 মিলিমিটার। সেই প্যানক্রিয়াটিক ডাক্টটার সাথে তুই কখনো কোনো একটা গাটের অ্যানাস্টোমোসিস করতে পারবি না। তখন এই ভ্যালুটা মনে রাখবি, দ্য কাট অফ পয়েন্ট when you can plan a, and this diameter is measured on CT itself. এটা তো সিটিতেই তুই পেয়ে যাবি। So the measurement that is required for drainage is diameter of PD is 7 millimeter minimum হতে হবে, preferably 10 millimeter. So যেই পেশেন্টের ধর হেডে ডিজিজ আছে, এখানটায় একটা স্ট্রাকচার আছে, obviously this part will become upstream dilatation হয়ে যাবে. So they usually get dilated when the disease is restricted in the head region, either a stricture or a stone. So in these cases, কয়েকটা প্রসিডিওর মনে রাখবি, দুটো প্রসিডিওর। একদম প্রথম প্রসিডিওর যেটা লেখা আছে সেটা হচ্ছে পাস্তোজ অপারেশন বলে তোরা লিখিস। একদম প্রথমে আমি ছবি এঁকে এঁকে তোদের বোঝাচ্ছি কি করা হয়। প্যানক্রিয়াসটা এরকম গেছে, এখানটা থেকে ডিস্টাল প্যানক্রিয়াটিক, যদিও এটা ড্রেনেজ প্রসিডিওর, ডোন্ট সে নাও, বাট কি করা হয়, এই ডিস্টাল প্যানক্রিয়াটেক্টমি করে দেওয়া হয়। ডিস্টাল প্যানক্রিয়াসটা ফাঁকা হলো, তাহলে এখানে এই প্যানক্রিয়াটিক ডাক্টের ওপেনিংটা হলো, এই ওপেনিংটার সাথে একটা রুলুপ জেজুনাম লাগিয়ে দেওয়া হলো। ঠিক আছে, এই সার্জারিটা একদম সবচেয়ে প্রথমে করা হয়েছিল। আই কান্ট রিমেম্বার দ্য নেম, একটু চেক করে নিবি। ইট ইজ ডুভালস সার্জারি বলা হতো, ডুভালস। পার্ডন? নো, দিস ইজ অরিজিনালি ডুভালস। কি? No, Duval did this surgery, and then this surgery has been abandoned. That means it is some kind of mixture between resection and drainage. But they usually won't drain because normal architecture অনুযায়ী ড্রেনটা হবে আপস্ট্রিম, এইদিকে ড্রেন হওয়ার কথা, যেখানে তো স্পিন্টার অফ পডাই আছে। So if there is any stricture or anything, they will not drain the head part, so it will not function. So next modification was done by Pustow-Gillespie বলে একটা সার্জন আছে, দুটো। You will check later. You will check later what I am saying. I know what I am saying. So this pancreas এরকম ভাবে পড়ে আছে, এটাতে কোনো রিজেকশন করা হলো না। এই যে প্যানক্রিয়াটিক ডাক্টটাকে খুলে দেওয়া হলো, যতটা ফুল লেন্থ খুলে দেওয়া হলো, and a part of jejunum, এটাও সাইড ওটাও সাইড, so side to side, side to side pancreatico jejunostomy. এই যে অপারেশনটা করা হলো, that is named as something like Partington-Rochelle surgery. But basically এই Partington-Rochelle surgery তে কি করা হয়? There is no resection. The entire pancreatic duct is open and pancreatic duct এর সাথে জেজুনামের একটা অ্যানাস্টোমোসিস করে দেওয়া হয়। এর মাঝামাঝি যে জিনিসটা আছে ও যেটা চেক করতে চাইছে সেটা হচ্ছে কমনলি Pustow-Gillespie অপারেশন। এটাতে কি করা হয়? ডুভাল যেটা রিজেকশন করেছিল সেই রিজেকশনটা ওরা করতো না। ডুভাল মানে tail of pancreas resection is not done and anastomosis is made. But this one is a very common procedure that is being often termed as Pustow, but that is not Pustow, that is Partington-Rochelle surgery. এই দুটো হচ্ছে তোর ড্রেনেজ অপারেশন। তারপরে যেটা হলো, ধর একটা প্যানক্রিয়াটাইটিসের পেশেন্ট পেলি যার ডাকটা খুব পাতলা, অর্থাৎ that has not dilated, but still those patient will have pain, তাহলে সেই পেশেন্টগুলোর জন্য আমরা এই রিজেকশন সার্জারিটা করি। এই রিজেকশন সার্জারিতে দুটো মনে রাখবি, বেজার্স প্রসিডিওর আর ফ্রেই প্রসিডিওর। এই বেজার্স প্রসিডিওরে কি করা হয় আমি জাস্ট গ্রস বলছি। এই যে প্যানক্রিয়াসটা আছে, এই প্যানক্রিয়াসের হেডটাকে এটাকে জাস্ট এই সি লুপের কাছে যতটুকু আছে সেখানে প্যানক্রিয়াটিক টিস্যুটা রেখে বাকি প্যানক্রিয়াটিক টিস্যুটা সব কোর আউট করে নেওয়া হয়। বেশি কোর আউট করলে এর পেছনেই আছে পোর্টাল ভেন, দ্যাট উইল বি ইনজিওর্ড, সো জাস্ট লিভিং এ থিন প্যানক্রিয়াটিক টিস্যু অন দ্য পোর্টাল ভেন অ্যান্ড অ্যারাউন্ড দ্য সি লুপ। এখানে প্যানক্রিয়াটিক টিস্যুটা রইল, এই জায়গাটা একটা গর্ত হয়ে গেল। ইন দ্য নেক অফ প্যানক্রিয়াস ইউ ডিভাইড দ্য প্যানক্রিয়াস, তাহলে এদিকে একটা প্যানক্রিয়াটিকের টিস্যু রইল, এদিকে একটা টিস্যু রইল। নাও ইউ টেক এ জেজুনাম, এইভাবে ঘুরিয়ে একটাই লুপ, এইভাবে ঘুরিয়ে এটার সাথে এন্ড টু এন্ড, তার মানে there are two anastomosis are made. One is the proximal head segment and the other is the body and tail segment of the pancreas. Two pancreatico-jejunostomy with a single Roux and Y jejunal loop. এই সার্জারিটাকে বলে ব্যাজার। It's very good. So they are done only when there is not enough dilatation to do a drainage procedure. And the phrase কি করা হয়, এই ডিভিশনটা করা হয় না। So exactly like ফ্রেতেও এরকম ভাবে কোর আউট করে নেওয়া হয় প্যানক্রিয়াটিক হেড। এইভাবে কোর আউট করে নিয়ে এই জায়গাটায় এখানটা থেকে এইভাবে প্যানক্রিয়াটিক ডাকটা চলে গেছে, এখানে সব এইটা হচ্ছে প্যানক্রিয়াটিক টিস্যু। আমি সরি একটা অন্য কালার দিয়ে দিই। সো এটা হচ্ছে প্যানক্রিয়াটিক ডাক্ট, আর এখানে এই হেড কোরিংটা বডি এন্ড টেলে করা হয় না, ইট ইজ অনলি অন দ্য হেড। সো হেড ইজ সিভিয়ারলি কোর্ড and then left like that, and then one jejunum is placed over there. So here also a Roux loop jejunostomy, here the neck is not divided, the pancreas remains intact. So in this case only one pancreatico-jejunostomy is fashioned. It's called phrase surgery. You just remember this, দুটো drainage procedure মনে রাখবি, you check it is Duval, Pustow and Partington-Rochelle and the other one. But what is important, you should be able to know that drainage is possible only when there is a sufficient dilatation of pancreas. And the advantage of it, we don't reject out any pancreatic tissue. So we preserve the function, whatever is left. But when the duct is not dilated, patient still having pain, and when there is a mass effect or suspicion of cancer, then we do these resectional surgeries, of which major is division of the pancreatic neck necessitating two pancreaticojejunostomy. And in case of this phrase surgery, when head coring is done, body and tail is left, it is the head that is severely cored out, all the pancreatic tissue left, and then an anastomosis with the pancreas, pancreaticojejunostomy kora hoy solitary, where the neck is not divided. That's it.